Usually when you talk about like a medical diagnosis, there's this expectation of precision, you know?
Right. Like it should be simple.
Exactly, like engineering or something. You break your arm, the x-ray shows a jagged white line, and the doctor just points at it and says, there it is.
Broken or not broken, it's totally objective.
Yeah, it's clean. But if you step into the world of chronic pelvic pain, suddenly that x-ray machine feels completely useless.
Oh, completely. It's a totally different landscape.
It is. We're looking at a diagnostic landscape that is incredibly murky. It's Monday, July 13th, 2026, and today we're diving into this medical blind spot that makes our most advanced imaging technology look, well, completely inadequate.
It really does.
We are on a mission to explore a hidden, highly misunderstood cause of chronic pelvic pain that affects, like, millions of women worldwide. And it's a condition that takes an astonishing average of 4 years to actually diagnose.
Yeah, 4 years. 4 years of patients just being bounced between specialists.
The worst.
Undergoing all these invasive tests and being told over and over that their results look perfectly normal. As we delve into the sources today, we uncover this particularly cruel irony, really, based on how modern medical testing is fundamentally designed.
Right, and we've got a massive stack of sources today for you, spanning clinical reviews, medical clinic guides, and vascular surgery resources. We're looking at pelvic congestion syndrome, or PCS.
Also known under the broader umbrella of pelvic venous disorders.
Yes, exactly. What we're really unpacking today is how this condition acts as a dynamic pelvic vascular congestion syndrome, altering regional blood flow in the pelvis. I know, it is a mouthful.
A lot of syllables, yeah.
But the underlying physics are fascinating. So why are we talking about this? Whether you are experiencing unexplained chronic pain yourself, or maybe you know someone who is quietly suffering, or you love dissecting a good medical mystery, this deep dive reveals how a simple trick of gravity creates a massive blind spot in modern medicine.
Because to understand the pain, we have to completely reframe how we view the pelvic region itself.
Right.
When people hear pelvic pain, they automatically think of reproductive organs.
Of course. The uterus, ovaries, cysts, things like that.
Exactly. Endometriosis is a big one.
Yeah.
But we need to pivot away from the organs themselves and look at the actual infrastructure supporting them.
Okay, let's unpack this.
Yeah.
Because before we can understand the pain, we really have to understand the plumbing.
The plumbing is key.
Yeah. PCS is not a reproductive disease at all. It is a vascular failure, like a mechanical failure. The sources use this really vivid analogy, describing PCS as essentially hemorrhoids of the pelvis, or like a broken one-way valve in the body's piping.
Yeah, and that mechanical failure happens deep in the circulatory system. So arteries pump this highly pressurized, oxygen-rich blood from the heart straight down into the pelvis.
Right.
And once that oxygen is delivered, the veins have to carry the depleted blood back up to the lungs and heart. But because humans walk upright, those pelvic veins are constantly fighting gravity.
Which is hard work for a vein.
It is. So to prevent the blood from just, falling back down into the legs and pelvis, the veins contain these tiny one-way valves.
Like little trap doors that only open upward.
Exactly.
The blood gets pushed up, the valve clicks shut, and the fluid is locked into its upward trajectory. But in pelvic congestion syndrome, those valves, specifically in the ovarian and internal iliac veins, they completely fail.
They just give out.
Yeah, the trapdoors swing wide open, so the blood flows backward in this process called venous reflux, and gravity just pulls all that volume down to pool at the bottom of the pelvis.
And the veins simply aren't designed to hold that much static fluid.
Right.
So they stretch out, they dilate, and they twist into these bulging varicose veins that are hidden deep inside the abdominal cavity.
Which sounds incredibly painful.
Well, the hydrostatic pressure of that stagnant column of blood pressing against the delicate vein walls, it's immense. It physically stretches the tissue beyond its elastic limit. And what triggers this failure is usually a combination of massive physiological shifts. Like pregnancy is the primary catalyst here.
Okay, because of the extra blood.
Exactly. Over those 9 months, a woman's pelvic blood volume increases by a staggering 60%.
60%.
Yeah, it's a colossal regional overload that's physically stretching the vein walls outward. And simultaneously, the body is flooded with estrogen.
Which does what to the veins?
Estrogen is a potent vasodilator, so it chemically relaxes and weakens the smooth muscle in the walls of the blood vessels.
Oh, wow. So you have the pipe being chemically weakened just as you are forcing like 60% more fluid volume through it.
It's a perfect storm.
Uh-huh.
And once they stretch too far, those valve flaps can't physically reach each other in the middle anymore to close. The trapdoor is just permanently jammed open.
That makes total sense when you put it like that. There is this weird anatomical quirk here, though, that I found in the reading. The sources note this happens on the left side of the pelvis far more often than the right. Why does the left side break down faster?
It's all about asymmetrical plumbing.
Asymmetrical plumbing. Okay.
Yeah, so on the right side of the body, the right gonadal vein drains directly into the inferior vena cava. That's the massive low-pressure highway leading straight back to the heart. It's a very easy straight shot.
But the left side is different.
The left side is a completely different architectural story. The left gonadal vein has to take a detour. It drains into the left renal vein, so the kidney vein, at this sharp right angle.
And the sources describe that kidney vein as a pretty rough anatomical neighborhood.
Oh, it's highly compressed. The left renal vein has to pass between two major pulsing arteries, the abdominal aorta and the superior mesenteric artery.
Okay.
Sometimes those two massive arteries can literally squeeze the vein between them like a nutcracker.
Ouch!
Yeah, this is clinically referred to as nutcracker syndrome.
Because it's literally crushing the vein.
Exactly. The pinch creates a sudden backup of pressure that shoots straight down the left ovarian vein, destroying those fragile one-way valves and causing massive pooling in the pelvis.
Okay, but wait. If the primary trigger is pregnancy pushing 60% more blood into the pelvis, why are we seeing this in women who have never been pregnant? Because the math doesn't add up if we only look at gestation. The data clearly shows nulliparous women. So, women who haven't given birth suffer from this exact same mechanical failure.
That's a great point. If we connect this to the bigger picture, we see that PCS is actually a multifactorial issue. It's heavily influenced by genetics and environment, too.
How so?
Well, about 10% of all women are simply born with missing or anatomically incompetent valves in their ovarian veins.
Just bad luck from birth.
Right. They lose the genetic lottery before they ever experience a hormonal shift. Furthermore, you have to factor in occupational hazards.
Like jobs where you stand all day.
Exactly. Careers demanding prolonged standing or heavy lifting nurses on 12-hour shifts, teachers, factory workers, they face constant daily gravitational pressure.
Just from gravity pulling on that broken system.
Yep. That chronic hydrostatic load can alter the regional blood flow over time, slowly degrading the veins even without a single pregnancy.
Okay, so knowing that these veins are physically stretched out, twisted, and, engorged with pooled blood, how does that translate into what the patient actually feels? Because having stretched veins doesn't automatically mean you feel them, but the pain described in these clinical guides is agonizing and incredibly erratic.
The erratic nature is precisely what defines it, actually. The pain of PCS is fundamentally dynamic.
Right.
It is not this constant, unchanging baseline.
Right.
It fluctuates intensely based on posture, the time of day, and shifts in that regional blood flow. The hallmark symptom is a dull, heavy, dragging ache in the pelvis that persists for more than 6 months.
And it gets progressively worse as the day goes on. Like you wake up feeling relatively okay because you've been lying flat in bed all night. Gravity hasn't been trapping the blood. But then, as you stand, walk, carry groceries, or pick up a child, the blood falls back down into the pelvis, the veins engorge, and the pain builds into this crescendo by the evening. It also flares up fiercely right before menstruation, right?
Yes, because that's when estrogen levels peak and blood flow to the reproductive organs surges.
Okay. But the pelvis is so crowded. It's like a crowded neighborhood where a loud party at one house keeps everyone else awake.
Yeah.
How does this venous swelling trick the body into feeling like other organs are failing?
What's fascinating here is the localized inflammatory cascade triggered by that swelling.
Okay.
When blood pools and stagnates in these varicose veins, the tissues become hypoxic. They're starved of fresh oxygen. This triggers the veins to release potent inflammatory markers straight into the surrounding tissue.
So this changes the entire environment of the pelvis.
Completely.
Because the pelvic cavity is incredibly dense, right? The bladder, the uterus, the bowel, the rectum, they're all packed in tight, sharing the same limited real estate.
Yeah, there's not a lot of extra room in there.
So when a network of veins swells to 3 times its normal size, it's physically competing for space and crushing the nerve networks of the organs next door.
And the nervous system in the pelvis is highly interconnected. That physical pressure combined with the chemical inflammation relentlessly irritates the surrounding pelvic nerves.
So the nerves get confused.
Essentially, yes. The nerves begin misfiring, sending distress signals that the brain misinterprets as coming from the adjacent organs. For example, the swollen veins are often wrapped directly underneath the floor of the bladder.
Oh, man.
So the bladder wall becomes inflamed and you feel severe urinary urgency. It mimics an interstitial cystitis or a raging urinary tract infection, but when the doctor runs a urine culture,
It comes back completely sterile.
exactly, completely clean.
And the same thing happens with the bowel. It mimics irritable bowel syndrome, but gastrointestinal tests find absolutely nothing wrong with the colon.
Nothing at all.
I mean, the psychological toll of this must be devastating. A patient spends years going to urologists, gastroenterologists, and gynecologists, getting perfectly clean test results while living in daily agony. They're essentially being gaslit by their own anatomy into thinking it's all in their head.
It's horrible.
Yeah.
It leads to severe depression and anxiety. Gynecologists actually refer to this widespread misdirected nerve irritation as the 3Ds of pelvic pain.
The 3Ds.
Yes, dysmenorrhea, which is severe menstrual cramping, dysuria, which is painful urination, and the third, which frequently damages marriages and partnerships, is deep dyspareunia, severe pain during or after sexual intercourse.
And the mechanism behind that last one is purely vascular, isn't it? Because sexual arousal naturally, physiologically causes a massive surge of blood flow to the pelvic region to engorge the tissues.
That's right. In a healthy system, the veins easily accommodate that surge and then efficiently drain it away afterward.
But not with PCS.
No. In a patient with PCS, you are pumping a massive volume of extra blood into a system that is already severely congested, inflamed, and mechanically broken.
Oh, wow.
So the localized pressure spikes drastically, severely stretching those sensitized vein walls, resulting in a deep, aching, sometimes throbbing pain that can last for hours or even days after intimacy.
Here's where it gets really interesting, though. If the symptoms are this distinct, a heavy, dragging pain that gets worse when you stand up and better when you lie down, why the 4-year diagnostic delay?
Well, think about standard medical imaging.
Like CT scans and MRIs.
Exactly. CT scans, MRIs, they all require the patient to lie flat.
Right.
But PCS is a gravity-driven condition.
No.
The second the patient lies flat, the blood drains out of the pelvis, the veins shrink back down to a near normal size, and the evidence vanishes before the technician even turns the machine on.
That is wild. It is the ultimate diagnostic blind spot. We have patients subjected to thousands of dollars of state-of-the-art imaging, and the methodology fundamentally fails the mechanics of the disease.
It does. The patient lies on the MRI table for 40 minutes, their pain subsides because they are flat, and the doctor reads a perfectly clear scan.
So how do you actually find it?
Specialized dynamic diagnostic techniques are absolutely required. A transvaginal duplex ultrasound could be a highly sensitive, non-invasive tool, but the technician must perform it dynamically.
Meaning the patient has to be evaluated while standing up or lying on a tilted bed with their head heavily elevated to force the blood downward, right?
Exactly.
You also mentioned the Valsalva maneuver in your notes earlier. You're basically asking the patient to purposefully recreate the intra-abdominal pressure that triggers their daily agony, just to catch it on camera.
Yes, you ask them to bear down, increasing that core pressure. If the valves are incompetent, the ultrasound will show the blood actively flowing backward, the venous reflux, in real time.
Incredible.
But while ultrasound is the accessible starting point, the absolute gold standard for mapping this failure is a pelvic venogram.
A venogram involves real-time X-ray video, right? Fluoroscopy.
Correct. An interventional radiologist performs this while the patient is awake but sedated. Using fluoroscopy, they make a tiny pinhole incision in the groin or the jugular vein in the neck and thread a highly flexible microcatheter directly into the venous system.
From the neck all the way down.
Yep. They navigate this catheter deep into the ovarian and internal iliac veins and inject a contrast dye.
So they aren't just taking a static snapshot. They are watching the fluid dynamics happen live on a monitor.
Exactly.
They physically watch the dye flow backward against the intended current, pooling in the pelvis and definitively mapping the exact anatomical failure. It removes every ounce of guesswork.
And it proves to the patient, finally, that the pain is real and measurable.
So what does this all mean for the patient who finally gets that venogram and sees the dye pooling? How do you fix a regional venous failure? Because, you can't put a cast on a broken internal vein.
Right. Treatment requires a stepped approach. The first line of defense is medical management, which is primarily aimed at symptom control rather than a structural cure.
Okay, like what?
Doctors often start with phlebotomics. These are medications containing active compounds, like flavonoids, that attempt to improve venous tone, reduce capillary permeability, and decrease the localized inflammation.
But, If the pipe is physically stretched beyond its elastic limit, a pill that slightly improves vein tone seems like trying to fix a blown tire with duct tape.
That's a fair comparison, which is why they quickly moved to targeted hormonal therapies, like medroxyprogesterone acetate or GnRH agonists.
That's quite the mouthful. What do those do?
GnRH agonists are powerful drugs that essentially trick the pituitary gland in the brain into pausing the signals that tell the ovaries to produce estrogen.
So you just shut the factory down?
By shutting down the ovarian axis, you drastically cut the estrogen levels, which removes the chemical vasodilator and shrinks the blood flow to the region.
Wow. It creates a temporary chemical menopause.
It does.
It can provide significant short-term relief, sure, but you can't suppress a premenopausal woman's hormones indefinitely without causing a cascade of systemic issues like severe bone density loss.
No, you absolutely cannot.
So since suppressing hormones is just a temporary band-aid with terrible side effects, the only permanent way out is to physically address the broken pipe. How do they actually do that?
This brings us to ovarian vein embolization, which is the cornerstone of modern, minimally invasive PCS treatment.
Embolization, okay.
Yeah, it's an endovascular procedure, meaning it is performed entirely from inside the blood vessel, often during the exact same appointment as the diagnostic venogram.
Oh, that's convenient.
The interventional radiologist uses that same catheter to deploy tiny platinum coils or sclerotic foam directly into the faulty dilated veins.
Okay, I want to understand the mechanism of that foam. How does a foam fix a dilated vein?
Well, it doesn't fix it. It destroys it.
Oh.
Yeah, the sclerotic foam is a chemical irritant. When injected, it intentionally damages the inner lining of the vein, known as the endothelium. The body's natural response to this targeted chemical injury is rapid inflammation and scarring.
So it scars over.
Yes, the vein walls collapse and scars shut permanently, aided by the physical blockage of the platinum coils.
But this raises an important question. If you permanently block and destroy a major pelvic vein, how does the deoxygenated blood get out of the pelvis? Don't you need that vein?
You'd think so, but our venous network is a highly redundant, interconnected web.
Okay.
Think of it like a dense city grid. If you permanently close down a major avenue that is completely backed up with traffic and massive potholes, the body's natural hemodynamics simply reroute the flow.
It just finds another street.
Exactly. The blood is diverted into the countless smaller, healthy cross-pelvic collateral veins that still have functional one-way valves. You eliminate the reverse flow, stop the pooling, and the regional congestion clears up.
It is brilliant. I mean, it's an outpatient procedure. You get local anesthesia, they block the broken vein, and you go home the same day with just a Band-Aid on your groin.
It really is a game changer.
But before embolization became the gold standard, the historical treatment, and unfortunately one that's still offered in areas without access to interventional radiology, was incredibly drastic, wasn't it? Major organ-removing surgery.
Yes. For decades, the ultimate cure offered for intractable pelvic pain was a total hysterectomy with bilateral oophorectomy.
It's taking everything out.
Surgeons would laparoscopically remove the uterus and both ovaries entirely. The logic was blunt. If you remove the organs demanding the blood supply and permanently eliminate the source of the estrogen, the venous congestion will resolve.
I mean, it might cure the PCS, sure, but the collateral damage of removing a 30 or 40-year-old woman's ovaries is a profound system-wide hormonal crisis. We hear the term menopause all the time, but surgical menopause is a completely different beast than natural menopause.
It is a violent physiological cliff. Natural menopause is a gentle, years-long transition where the ovaries slowly wind down hormone production, allowing the brain, bones, and cardiovascular system time to acclimate.
It's gradual.
But surgical menopause happens the second the surgeon cuts the blood supply to those ovaries. The patient wakes up in the recovery room with near zero ovarian estrogen and a 50% immediate drop in overall testosterone.
Wow. And the immediate symptoms alone, severe hot flashes, night sweats, profound mood swings, insomnia, vaginal atrophy, they just hit like a freight train.
They do.
But it's the invisible, long-term systemic cascade that is truly terrifying.
Because estrogen is incredibly protective. It has receptor sites all over the human body. When a young woman loses her ovaries, she loses the neuroprotective benefits of estrogen, facing an increased risk of early-onset dementia.
Which is huge.
She faces accelerated severe osteoporosis because estrogen is vital for bone remodeling. Her risk for cardiovascular disease and stroke skyrockets. You are essentially trading a localized vascular plumbing issue for a systemic, life-altering endocrine disease.
Which makes hormone replacement therapy, or HRT, not just a comfort measure, but critical life support for these women to mitigate those severe long-term risks, at least until they reach the age of natural menopause. And there are vital nuances to the HRT protocol, too. Like, if the woman underwent this radical surgery because she had severe endometriosis concurrent with her PCS, the doctor can't simply prescribe standard estrogen replacement.
Right, because unopposed estrogen is the exact fuel endometriosis uses to grow.
It feeds it.
Yes, even with the uterus and ovaries gone, microscopic deposits of endometriosis often remain hidden on the bowel or pelvic sidewalls. If you flood the system with pure estrogen, you reactivate that disease and even increase the risk of those deposits mutating.
Oh, that's awful.
Therefore, she requires a combined HRT of both estrogen and a progestogen to keep the endometriosis suppressed.
It highlights just how complex and delicate the endocrine balance really is, and it proves exactly why minimally invasive endovascular options like embolization are an absolute miracle.
A total miracle.
You preserve the organs, you protect the entire hormonal axis, and you selectively shut down the broken plumbing. I mean, we started this deep dive assuming medical diagnoses were as straightforward as an X-ray of a broken bone.
And we found out they aren't.
Right. But we've uncovered that for millions of women, chronic pelvic pain is a ghost in the machine. It is a dynamic pelvic vascular congestion syndrome altering regional blood flow, where failed valves let gravity drag blood backward, creating a localized inflammatory firestorm that mimics failing bladders and bowels.
And because our modern imaging is performed lying down, the gravity-driven evidence vanishes, creating a diagnostic blind spot that leaves women suffering without answers for years. But when caught dynamically, a radiologist can fix it in an afternoon with a catheter and some platinum coils, saving the patient from the terrifying cliff of surgical menopause.
So to you listening, if you, your partner, your sister, or your friend is suffering from unexplained chronic pelvic pain that feels heavy, dragging, and gets worse after standing all day, it might not be a mystery, and it is certainly not in their head. It might just be gravity.
Which brings us to one final, profound unknown in the data we analyzed today.
Oh, right. Let's hear it.
The anatomical studies show that roughly 10% of all women are walking around with incompetent, completely broken ovarian vein valves. Yet, only about 60% of those specific women ever develop the pain and debilitating symptoms of pelvic congestion syndrome.
Wait, meaning there are women out there right now with the exact same broken valves, the exact same reverse blood flow pooling in their pelvis, but they feel absolutely zero pain. The inflammation just never triggers.
That is exactly what the data suggests. It raises an incredible question for the future of vascular medicine. What is protecting that other 40%?
That's a great question.
Is there a hidden genetic shield regulating their inflammatory response? Is there a specific type of pelvic floor muscular tone acting as an internal compression garment?
Like natural compression socks for your pelvis.
Exactly. Or perhaps an undiscovered dietary element that allows them to tolerate this massive regional vascular overload completely pain-free.
Now that is something to ponder long after we sign off. It just goes to show you think you're taking a clean picture of a simple problem, but the closer you look, the more fascinating the human body becomes. Until next time, keep diving deep.